Hello, everyone. It's my pleasure today to introduce Amanda Vinson. Dr. Vinson is a transplant nephrologist in Nova Scotia Institution in Halifax, Canada, and she will present her recent AJT paper about COVID-19.
Okay. Well, thank you so much for the opportunity to be here to talk about my paper, The Risk and Consequence of Breakthrough SARS-CoV-2 Infection in Solid Organ Transplant Recipients Relative to Non-Immunosuppressed Controls. I do have financial disclosures shown here. So as everyone on this call will know, COVID-19 has significantly impacted solid organ transplant recipients. While vaccination may benefit the overall community, the benefit in immunosuppressed transplant patients has been questioned. There's been a report of poor antibody response to mRNA vaccination in transplant recipients, and most of you will have seen this slide or a similar slide suggesting that after 2 doses of an mRNA vaccine, up to 46% of patients do not mount an antibody response, and this is in transplant recipients. Some studies have demonstrated increased cellular immunity post-vaccination in transplant recipients. However, others have shown significant impairment of both humoral and cellular immune response. And interestingly, very few studies have actually examined the clinical COVID outcomes in transplant patients after vaccination. Therefore, the objectives of this study were to assess the impact of vaccination on breakthrough COVID-19 and complications of breakthrough COVID in solid organ transplant recipients and in a non-immunosuppressed or immunocompromised general population control group. The study cohort included adult patients more than 18 years of age, identified from across the United States using the N3C, or National COVID Cohort Collaborative Enclave. This is an electronic health record repository, and we included patients who developed COVID-19 from December 10th, 2020 to April 4th, 2022 from 36 sites. This figure shows the data partners contributing data to the COVID-19 registry, but again, we only used 36 sites with complete data. We included information on solid organ transplant recipients and non-immunosuppressed general population controls. This is defined as patients excluding autoimmune or immunologic diseases, bone marrow transplant, HIV, multiple sclerosis, or malignant neoplasm. So our study dates went up to only April 4th, 2022, but for context, as of August 25th, 2022, the N3C Enclave included data on nearly 6 million COVID-positive patients. The exposure of interest for our study was vaccination status. We define this as VAX2 being greater than or equal to 14 days after 2 doses of an mRNA vaccine or 1 dose for Johnson & Johnson or Janssen vaccine. We compared this to those with unconfirmed vaccination status, defined as not having a record of prior COVID-19 vaccine. The outcome of interest was cumulative incidence of breakthrough COVID-19 in the 6 months following VAX2, and we examined clinical outcomes in the 90 days after breakthrough COVID, including MARS, or major adverse renal or cardiac events, MACE, acute kidney injury, mortality, hospitalization, and a composite of ventilation, ECMO, or death. In those with breakthrough COVID following VAX2, so these are the patients who were vaccinated and subsequently went on to develop COVID, separately in transplant and non-immunosuppressed patients, we examined the proportion of patients developing each of those outcomes in the 90 days after breakthrough COVID. And we used multivariable Cox proportional hazard models or logistic regression as appropriate to examine the adjusted risk of VAX2 versus those with unconfirmed vaccination status for each outcome. And patient time was censored at greater than or equal to 14 days after a 3rd vaccine dose, non-COVID death or transfer to hospice, or the end of the study period. And then importantly, we repeated this analysis in a small subgroup of patients with VAX2 and an additional vaccine dose, which we labeled VAX3. So this is our baseline characteristic table for those developing COVID-19 in solid organ transplant patients by vaccination status. So unconfirmed vaccination status, primary VAX2 series, what was previously determined to be the primary series, and VAX3. Importantly, I want to highlight a few things. So those with a kidney transplant made up the highest proportion of patients with solid organ transplant, not surprisingly, followed by liver transplant, lung, and heart transplant, making up smaller proportions. In addition, as expected, if you look at patients developing COVID-19 in the pre-Delta period, there was a higher proportion of patients with unconfirmed vaccination status. And if we look at those developing COVID-19 infection during the Omicron period, a higher proportion had previous VAX2 or VAX3. This is simply by virtue of the timing of when vaccines became available. In Table 2, we looked at baseline characteristics of patients with COVID-19 in the non-immunosuppressed patients by vaccination status. Again, those with unconfirmed vaccination status, primary series, what was previously called the primary series, or VAX2, and then VAX3. And then again, not surprisingly, if we look at those who developed COVID-19 during the pre-Delta period, a higher proportion had unconfirmed vaccination status, and of those who developed COVID-19 breakthrough infection or COVID-19 primary infection during the Omicron period, a much higher percentage with VAX2 or VAX3, again, by virtue of when the vaccines became available. I do want to highlight here, just because I have an interest in sex and gender and kidney transplantation, but if we look at in the general non-immunosuppressed population, the proportion of females with unconfirmed vaccination status, a little bit higher than the proportion of males with unconfirmed vaccination status, but a significant increase up in the percentage of females versus males with either breakthrough COVID-19 after VAX2 or VAX3, suggesting either that females were more likely to become vaccinated or more likely to develop breakthrough COVID-19 after vaccination. And this is the point of a future study we're working on currently. So breakthrough COVID occurred in nearly 5,000 patients with the transplant and nearly 420,000 patients who are non-immunosuppressed over a median of 149 days in the transplant population and 201 days in the non-immunosuppressed cohort. And this was statistically significantly different. Relative to those who are not immunosuppressed, transplant was associated with breakthrough COVID with an adjusted hazard ratio of 1.76, which was highly statistically significant. If we look at an organ-specific analysis, again, you can see here in the cumulative incidence of breakthrough COVID-19, lowest cumulative incidence was in the non-immunosuppressed population, which is not surprising, followed by liver transplant recipients, with some overlap in the other organ types. But in an adjusted analysis, lung recipients were highest risk with an adjusted hazard ratio of 2.11 for breakthrough COVID after 2 doses of mRNA vaccine or 1 dose of Janssen & Janssen, what we're calling VAX2 for this study. And liver recipients were lowest risk with an adjusted hazard ratio of 1.39. So if we look at our results table, this is table 3. It's maybe a bit confusing, but essentially what we're looking at here is the combination of transplant recipients and our non-immunosuppressed control population to look at the adjusted risk of solid organ transplant for breakthrough COVID-19. So again, we're looking at all periods at this point, looking at, importantly, the risk associated with solid organ transplant, so a hazard ratio of 1.76, which I just told you. And if we look at the same analysis, the only difference here is we're looking by organ type, a hazard ratio of 2.11 for lung recipients, 1.39 for liver recipients, and similar risk of about 1.81 or 1.83 for kidney and heart transplant recipients. Because in this analysis, we're looking at the risk of breakthrough COVID-19, we weren't able to look at the risk of the sort of benefit of VAX2 compared to those with unconfirmed vaccination status, because we wouldn't have a time zero for those with unconfirmed vaccination status. So instead, what we're looking at is the relative benefit of those with a 3rd dose of an mRNA vaccine, so VAX3, compared to those with VAX2. And what you can see is, not surprisingly, in the overall population, VAX3 was protective compared to those who just had VAX2, and pre-vaccination COVID status was also protective. Here we expand out to look at wave-specific risk. So again, pre-Delta wave, and Omicron wave. I want to highlight a few things here. If we look at the risk associated with advanced age, so an age greater than 65, significantly associated with an increased risk of breakthrough COVID in the pre-Delta era, but an attenuation of that risk over the waves, such that actually during the Omicron wave, if you were above 65, you actually had a lower risk of breakthrough COVID than the younger patients. I also want to highlight the fact that if we look at the risk associated with solid organ transplant status, highest risk was in the pre-Delta period, where there was a hazard ratio of 2.35 for those who had a solid organ transplant for developing breakthrough COVID-19 infection. And again, sort of an attenuation of that signal over time. And if we look at the culprit immunosuppressant, not surprisingly, I think most of us recognize that MMF is the main risk factor for breakthrough COVID and adverse COVID outcomes. Highest risk, again, in the pre-Delta period with a hazard ratio of 1.76, with a waning of that risk over time associated with MMF. If we change gears a little bit and look at the risk of complications in a subpopulation who develop breakthrough COVID, you can see in the blue bars the risk of each of these outcomes in the 90 days after breakthrough COVID infection in the non-immunosuppressed population, and in the orange bars, a much higher risk in those with a solid organ transplant. So this is looking at those who have VAX2 and develop breakthrough COVID. And if we look at the risk in solid organ transplant recipients who are vaccinated versus the non-immunosuppressed control population who are vaccinated, not surprisingly, a much higher risk. So the risk of MARS, 12.9-fold higher, acute kidney injury, 21.6-fold higher in transplant recipients, and mortality, 10.3-fold higher in transplant recipients who are vaccinated versus the versus the non-immunosuppressed population who are vaccinated. If we go on to look at organ-specific risk, overall, you can see that the risk by organ type is fairly similar with a few notable exceptions. The risk of MACE was highest in heart transplant recipients, And the risk of death or the composite outcome of ECMO ventilation or death was statistically higher amongst lung transplant recipients. So if we look at for this analysis here, we're looking at the risk of outcomes after breakthrough COVID-19 infection was established in those who had VAX2 versus those with unconfirmed vaccination status. And here in the yellow squares, we're looking at the non-immunosuppressed control population. And what you can appreciate pretty handedly is that there is a clear benefit with VAX2 compared to those with unconfirmed vaccination status for each of the outcomes examined in the 90 days after COVID infection: MARS, MACE, acute kidney injury, mortality, hospitalization, and then this composite outcome of ECMO ventilation or death. If I superimpose in here the relative benefit with VAX2 versus unconfirmed vaccination status in transplant recipients, what you can appreciate is that there is a statistically significant benefit of VAX2 compared to having unconfirmed vaccination status if you're a transplant recipient, but not to the same benefit that's observed in the non-immunosuppressed general population. I want to highlight mortality because it's arguably one of the most important outcomes. And you can see that VAX2 versus unconfirmed vaccination status in the general population, strongly protective with a hazard ratio of 0.37 for dying after breakthrough COVID, but also a very pronounced benefit in solid organ transplant recipients with a 33% reduction in the hazard ratio of dying amongst transplant recipients who had VAX2. So this is the same figure I just showed you for context, but here I've superimposed in the risk by organ type. Now, as we start subdividing down by organ type, the numbers get smaller and appropriately so the confidence intervals get a bit wider. So there's more instability around the true point estimate here. But ultimately, there is no significant difference by organ type in terms of the preventative effect of VAX2 versus unconfirmed vaccination status after breakthrough COVID, but limited by small sample size and small event rates. This is, again, the same figure I've just showed you for context, but I'm going to superimpose in VAX3 status. So here we're looking at in the thatch bars, we're looking at the benefit of VAX3 versus unconfirmed vaccination status. And what you can appreciate is that in the non-immunosuppressed population, so the yellow squares, there does seem to be some additional benefit with VAX3 compared to what's observed with VAX2. And in the transplant population, so the kind of blue squares, there's additional benefit. It looks like almost additional benefit with VAX3 compared to what's observed in the general population. But again, because of the small sample size, few events rates and short follow-up time, wide confidence intervals and some instability around the true point estimate here. So certainly limited, but a signal that there might be additional benefit in transplant populations. So at the time the study was written, it was the largest study to examine clinical outcomes after breakthrough COVID in solid organ transplant recipients with VAX2. We compared risk in VAX2 transplant recipients to those with unconfirmed vaccination status and to VAX2 in the non-immunosuppressed population. It was also the first study to detail organ-specific clinical outcomes after breakthrough COVID. And then in the small subset of patients where we had data available, we were able to examine outcomes after breakthrough COVID in patients with an additional booster dose or VAX3, what's currently considered a primary series. There are some important limitations though. So through the N3C, we don't have access to COVID negative controls. And so we weren't able to incept our cohort at the time of vaccination to determine the number of patients who actually never went on to develop breakthrough COVID. We had to only look at those with breakthrough COVID because that's what we had available to us. Likewise, we couldn't confirm the control group was unvaccinated. It's very possible that there were patients who had undocumented vaccination who were contaminating our unconfirmed vaccination status kind of unvaccinated control group. But if that's the case, it would only serve to attenuate the benefit that we're seeing, and the true benefit in the real world would only be greater in the vaccinated patients. Finally, and most importantly, this study examines breakthrough COVID outcomes after what's currently considered incomplete vaccination, looking at, again, 2 doses of a 2-dose series or 1 dose of Johnson & Johnson or Janssen, so VAX2. And again, even since this paper's come out, we're now calling 2 doses is not even considered a primary series anymore. And in this case, we only had very small numbers of patients with VAX3 or VAX2 plus a booster. So in conclusion, solid organ transplant patients are at an increased risk of breakthrough COVID-19 infection after VAX2 compared to what's observed in the general population. VAX2 in solid organ transplant patients has a small but very significant reduction in the risk of adverse outcomes after breakthrough COVID. But not surprisingly, I think most of us know that transplant recipients do remain at high risk and should continue to use caution even after vaccination. And then potentially VAX3 may have a greater relative benefit in transplant recipients than what's observed in the non-immunosuppressed general population. However, this is something we're looking into in further detail and certainly requires more study. So with that, I would like to thank you for listening and for the invitation to speak here. I'd like to acknowledge the N3C for allowing me to use their data for these studies, and particularly Dr. Rosalind Mannon, who's the head of the solid organ transplant team through the N3C, and my co-authors. And I'd be very happy to take any questions.
That was great, Amanda. Thank you. I have a couple of questions here. One question about the use of EvoShield. Do you know at that time when the third booster was available, do you examine if EvoShield was protective in any means?
So this study was done before Evusheld was widely available. And in fact, I think it was done before Evusheld was available at all. So none of these patients received Evusheld, but that's actually another study we're currently looking into is, we think there's benefit with Evusheld, but we actually don't have a large study looking at this in transplant recipients. And so we're looking into that as well.
Great. How about medications in terms of myfortic? What was patients? Did you look at medications if patients who were not on myfortic were less likely to have breakthrough?
We didn't look at a subset of patients who are not on myfortic, but we were able to adjust for myfortic. So we adjusted for standard immunosuppression like MMF or myfortic, tacrolimus, cyclosporin, and prednisone, and we were able to adjust for those factors. And certainly MMF was found to be one of the biggest risk factors for adverse outcomes after breakthrough COVID-19 infection, even amongst our vaccinated population. And so we didn't look at a population who were not on MMF because the numbers would get quite small. As you're aware, most patients will be on MMF or some version of an antiproliferative, but we did adjust for that. And we did see that there was a strong association with risk with MMF.
Makes sense. One more question. It says that seems there was a cumulative incidence of COVID-19 post-vaccination in various solid organ transplant recipients, and that liver recipients had a higher risk initially, but then goes down to seem to become the lower compared to non-immunocompromised patients. So did the liver have initially higher risk, then went down?
I'm not sure actually about that, but let me turn back. I know the slide you're talking about. Let me get back to that slide. Certainly, if they do, it's not something that we looked at or examined. So it's this slide, I believe. So I think, yeah. So it's I suspect it's this slide you're talking about. So I think there's so this cumulative incidence, because we defined breakthrough COVID-19 14 days after vaccination. So time zero was vaccination, 14 days. That's why you see the flat line initially. This is where we started accumulating events, or the cumulative incidence starts kind of at the 14 days after time zero, which was vaccination. And I guess maybe there's a bit of instability around whose highest cumulative incidence early on, but I wouldn't necessarily say there's a dramatic higher risk, but certainly we didn't look at the timing of when these events were happening by organ type. So that's a really good question, and something we could certainly look into.
Wonderful. Thank you so much, Dr. Vinson. That was great. We'll end our meeting here.